Thank you. Thank you so much for coming out today. Research is so important to the understanding of mental illness. It is through research that we're able to provide more effective treatment and reduce suicides. We are so lucky to live in Chicago and be surrounded by so many universities where we're able to have a different AFSP grant recipient speak every year. Today we're honored to have Dr. Pavuluri come and speak with us about brain circuitry, informed intervention for suicidal teens with bipolar disorder. Please welcome her.
I am absolutely honored to be invited by American Foundation for Suicide Prevention and Rochelle and Meg and everybody else on the board and the research donors for giving me the money to do the work, as well as the goodwill of all of you for wanting to hear and make a difference in your loved ones and those you know, and how we all can collectively improve how we survive in this world and make it like an amazing, thriving place for everyone else. So that's the concept. And you know what? These days, it's interesting. Research is a small part of what we do. On any given day, when you're exposed to so many stimuli and distresses and opportunities and amazing things all together, it's so hard to kind of go past the barriers that come in the way of survival sometimes, just based on one piece of research, right? So it's a matter of putting all the pieces of research together, as well as clinical experience of having seen many youth on a daily basis and taking care of the families. I would love to offer you something that brings a lot of clinical nuances in taking care of youth, as well as research of many of my colleagues in the country and across the globe that published up to the point of 2015, i.e. yesterday. And also the research, a little bit of what we have done and put it together to deliver to you today. And that's a lot of promise, it seems, but it goes fast, I hope. And also, I hope that little vignettes of what I say in it, you could also use it for yourself in enjoying life, And it's a little bit like a, hopefully, therapeutic in the process, because after all, I'm a shrink, right? So we'll just work it together, and we'll expand and shrink, though. And so I'll take you through the ride. And so, let's see. I have been funded by several organizations, including American Foundation for Suicide Prevention, as you saw here. And also, there are no current conflicts, but only an immense gratitude for everyone who helped me with this work. So I would like to translate it because mostly the research or clinical work is a purpose-driven work trying to attend to helping youth. And so what I will do is, even science need to be delivered in an art form. So first, this is the clinician who are the drivers who drive everyday's, crises and help them problem solve the children and teens, whereas we figured out, or we're trying still to figure out, what is the mechanics behind the thinking process of the brain through brain imaging in pediatric bipolar disorder. Or, pediatric bipolar disorder, by the way, is nothing more than severe affect dysregulation along with a conglomeration of symptoms that I'll describe in a minute. So it serves as a purpose of severely dysregulated children and how they look like in their brain is what I would show. And the physics of genetics is what I won't be talking to you that much, but maybe a point or two. So I would break this presentation into 4 parts: A, assessment; B, brain function; C, chemistry or chemical intervention; and D, dynamics and delivery of treatment at a very individual family level. So how do we do this? A, B, C, D, okay? So A. So how do we understand this severely dysregulated children, right? So these kids, a lot of these bipolar teens, or mood dysregulated teens, to be honest with you. I'll tell you why I call them interchangeably sometimes severely mood dysregulated. They come with severe depression sometimes, covering themselves with blankets or cutting their wrists, and, irritable, slamming doors, grades falling down, and, covering themselves with a black hood like that, and, but sometimes, lots of, embellishments to find their own identity to themselves. They wouldn't want to talk to you. They're just angry with their parents for bringing them to me. And then somebody like that thinks it's just a depression and give you serotonin reuptake inhibitor, and that becomes like fully blown mania instantly. See, these SSRIs without proper treatment of mood or mood dysregulation are like ammunition, almost toxic to these children, and result in mixed mania. And so I say again and again in the community, please look at either family history or agitation or severe explosive anger. That is not depression. It's more than depression. It's mood dysregulation. And look for other symptoms, possibly mania, or in the spectrum of not so fully formed mania. So that's when you give mood stabilizers really and stop this SSRIs, and then it becomes like a mixed episode, and sometimes they get better and then they get worse again after a while because they develop tolerance sometimes for one medication. So it's a combination of medications that often work, because single medication doesn't really work very well in these kids. And then they come down, and then you have also this yellow part in the middle. That's the ADHD that continues to be there in the background. It could be a result of bipolar diathesis or mood dysregulation, or it could be independent ADHD. So there is a chronic morbidity in these children and mixed mood dysregulation. See these little affective storms that are there? Those are present when kids slam the doors and yell and scream and call you stupid and idiot and all those things. So it's not like they really don't like you. They're expressing their anger, their inability to cope, poor problem solving, and struggling within themselves, So that is part of their, what people call sometimes disruptive mood dysregulation disorder, that is often present almost like a personality in the backdrop of these mood dysregulated kids with major disorders. And often it's not diagnosed when you have a major disorder, but it's diagnosed if it's present by itself, which I will show you. So in the DSM-5 classification, there is a mood, bipolar, and related disorders with less number of symptoms or more symptoms but less duration. That doesn't quite meet the criteria of bipolar disorder. And bipolar disorder means you have hypersexuality sometimes, severe sleep deprivation. They have too much energy and they don't sleep, and they're just very, very outspoken and very explosive, as well as giggly, silly, elated, excited, and chunks of hyper mood, and then chunks of depression. Even if it is chronic illness, if there's a waxing and waning, you would think it's bipolar disorder. And if it is, less number of symptoms or less number of amount of duration, then you call it unspecified or specified bipolar and related disorder, because you don't want to commit to the actual diagnosis. And disruptive mood dysregulation disorder is nothing but chronic irritability that's constantly present, along with temper tantrums that are very severe, up to 3 or 4 times during the week, and it repeats a lot of the time, for more than a year, and it's present along with these disorders sometimes, but you don't diagnose it if these major disorders are present. So this is a backdrop often with bipolar disorder, but this disruptive mood dysregulation can exist by itself, and it does not have all the features of depression, for example, or grandiosity, high increased energy, low sleep. All those things are not present here. So these are all closely related, and I'll tell you how they're closely related when I explain to you the wiring of the brain in a minute, okay? So when you come to suicide, I'm also in the American Academy of Child and Adolescent Psychiatry, the Psychopharm Initiative work group, and there is also several other work groups that we work there in the academy, and we put out these point statements which are very important to clarify. Suicidal ideation is something like a fleeting suicidal ideas that children or teens have, or anybody has, and suicidal intent is when you really want to end your life, and suicide attempt is when you actually want to have the intent and you attempt to end your life. Parasuicide or self-harm is when teens feel a relief when they cut their arms. So there's increased energy, agitation, irritability, and somehow if they cut, they feel like a release of some kind of emotion because they feel the pain and they just like release the grit and anger through that cutting. And that's not necessarily suicide attempt. And then the suicidality is any ideation along with behavior that's there. We prefer not to use the suicidality as a term, and suicide or completed suicide is of course the sad part of a completed suicide. It's an urgent issue because it's the third common cause of death in 10 to 19 years of age. And highest suicide in bipolar disorder versus all others. The completed suicides in bipolar disorder are common, and the highest among those in childhood disorders. And by 18, 50% will attempt suicide in bipolar disorder. And firearms, hanging, and poison, as you know, are the common ways of ending life in general. So we'll come back to this. I feel that one is too many in any case, right? I mean, think about one person. I mean, my son came from Barcelona yesterday, like 2 days ago for spring break. They went on some college trip. And then next day I heard that the plane crashed, the one going from Barcelona to Düsseldorf. And I just felt like one day I couldn't even reconcile that he could have been in a plane that started in Barcelona. Imagine how parents have to reconcile with anything that happened to a child. It's just irreconcilable, but only something that you learn to live with somehow. So we want to make that every life that's lost or any life that's lost, we want to make that meaningful towards helping those that we survive on the earth to make it a better place for them. And that's kind of my, of course, we all agree on that. So what to watch? Repeated, these are the ones that are really important for us to think. Repeated attempts, oh yeah, they always cut themselves, that's just a show for attention. Well, attention is for a reason, right? They want attention because they want love, attention. Of course you give endless love, but still some kids are born in such a way that they need endless love. So it's that repeated attempts, your visits, major depression, substance abuse. First 6 months after an attempt is a critical time. Negative events happening, bullying. Bullying is a big thing. That's sort of like negative stimuli, basically. I'll tell you, rejection sensitivity. Single attempters, fatal and serious ones are also very likely to be successful ones. Romantic disappointments in teens, or minor disciplinary acts and arguments in children where problem solving hasn't really caught up with them as well, and they just kind of impulsively do this. Hopelessness linked to poor problem solving, mood dysregulation, panic, substance abuse, like anxiety and those kinds of coexisting disorders, explosive anger and impulsivity, so emotional dysregulation again, and some brewing problems of physical and sexual abuse that resulted in very low self-esteem and internal torture that these kids or teens experience. So these sort of experiential problems of mental health, as well as perceived problems, as well as past experiences, appear to be I mean, you all sort of know about it. The fact that you're all in this room means that you thought about it again and again and again on these things, you know, at least most of you. So for me, I feel a little bit humbled to talk about these kinds of stuff. But, you know, for the sake of completion in the story and in the context, I might just say it anyway. So the tragic story is usually it's a rapid decision to act, a cognition to solve the problem through escape or end the emotional disappointment and pain and hurt with an inciting event that tips the balance, altered by substances, and availability of lethal method to execute mental illness and trauma. This pretty much sums up the previous slide. So sort of, you know, that rapid decision is nothing but what we would be covering impulsivity, and that one emotional disappointment and coping with pain and reactivity to negative stimuli is what we are going to study. That's the research that we have done in order to understand these parts and see how we can help with a disorder, mental illness. So that's what we will discuss. So our model was that there's a completed suicide, there's sometimes there is the wishing to be dead, then there is ideation, specific plan, suicide attempt, and completed suicide. Then there is the impulsivity and also affect dysregulation that kick starts this, and they go suddenly anywhere from here to here without even these steps. And that's what is not acceptable, and that's what we wanted to study. So let's open the brain and see how we can understand how the machine works in the brain. So fMRI is functional magnetic neuroimaging. It's basically how the blood flows to different parts of the brain when you give them the puzzles to do, little puzzles in the magnet, and then you figure out where the deficits are and how the blood is flowing and how the brain is working based on the blood flow. Okay, it's a neuroscience. It's a golden age of neuroscience, actually. And so we will look at the brain parts, okay? This is basically, I don't want to bore you with too much, but this is the brain, right? And so basically, when you look at this dorsolateral prefrontal cortex where the Mickey Mouse ears are here, that's where dorsal means top, lateral means side, dorsolateral prefrontal cortex. That area is where the brain concentrates, solves problems, and information is processed, like a CEO of that part of the brain, thinking part of the brain, is here on the top where the Mickey Mouse ears are. And ventrolateral, see at the bottom of the brain here, and laterally also, is ventrolateral prefrontal cortex. That is the CEO of emotion regulation. That is the CEO that regulates the emotional processes. So this is the amygdala at the bottom of the brain. That's like the frontline worker, these two left and right amygdalas, and they receive the emotions. So if you look like this, stop it, means suddenly the amygdala would just become like a fountain of, it triggers the emotions and it processes the emotions, and there's a fountain of emotions in the amygdala. If it is overreactive, then that's like really firing up and down, up and down. So that amygdala is controlled by this emotional CEO, and then it also talks to this thinking CEO. So the thinking CEO and emotional CEO talk to each other and control this amygdala. You got it? You're with me with that? Yeah, this is the frontal or prefrontal cortex, or it's actually front part of the brain. This is the frontal cortex, and this is the subcortical, sub means below the cortex. So the amygdala are here. So this is frontal limbic. Amygdala is also limbic system. So a lot of people call it frontal limbic system. Okay? That's all it is. Frontal limbic or prefrontal and amygdalar circuits, or it is emotional circuits. So those are the main things. There are a lot more other areas like insula, for example. It just is right here just behind the emotional control area, and a lot of this mindfulness is processed by the insula because it also is an interesting part, like a little pocket on either side, like, you know, present, and that is the one that processes all these emotions and then bodily reactions, like you get very aroused and huff and puff, you know, when you're upset. That is felt, the emotion, the bodily feelings of your emotions are processed by this insula, and then it talks to this, and then this one will process and problem solve along with this trigger of emotional control area, and then they all work together. Okay, so when you give medications to calm down, it's the insula that calms down also, you know, in helping calm down. So the amygdala is the one that is processing initially. This one, bodily emotions are processed here, thinking and feeling. Okay, and then I won't go into the concentration areas, but I will tell you in a bit. So this is the brain model we developed in our lab, and this is frontal. See, this is clear here, emotional control area and thinking control area, and then this is the amygdala frontal limbic, then this is the interface circuit, this is the cognitive circuits involved in ADHD or attention or even simple concentration, and this is the impulse control with the basal ganglia. This is also a subcortical area called basal ganglia or caudate nucleus. So when this emotional control area is also connected to this caudate, and this one is the one that's responsible for impulse control. Okay, so in fact what is most interesting is emotion control CEO and impulse control CEO are the same ones, the ventrolateral prefrontal cortex. You get it? So when you think next time, they're all linked. You know how thinking and feeling are linked right here, and then concentration and impulse control and emotional control are linked together. You see what I mean? So these are impaired or affected in bipolar disorder. That's what I will show you. And this one is occipital cortex. That's the one that represents the eyes. So you see, with, you know, it's also at the back of the brain, so people always get confused. But when you see anything that goes in the screen is here for your brain, okay, at the back. So that's where you see the angry face, and then suddenly the amygdala fires up. This before it even reaches the prefrontal cortex. You see what I mean? So it doesn't even reach your thinking part of the brain, and it's almost like a brain in the knee. You know, you suddenly reflex reaction or reptilian reaction, people call it, you know, like kind of thing, you know. So that one is very quick, right? And this one is a quick reactive circuit called occipital limbic associative circuit. So you can see now how this is a phase response or recognition of phases circuit. All these are impacted in bipolar disorder. This is the brain model that we have figured it out in our lab. And so this is another interesting way of our research to show through our research, where we did what is called dynamic causal modeling, and we showed how the brain circuits work in bipolar disorder. That's highly dysregulated brain, in other words. And you look at this where amygdala is, how big this is. These are like various roads as you problem solve or regulate emotions or think. So you can see how in bipolar kids, this amygdala is the road, or the amount of roads that pass through amygdala are so much. So for example, if you want to go to New York, you go through Boston a lot of the time, then Boston would look big. You know what I mean? So they used amygdala a lot, and they're always reacting. That's why it looked so big. And whereas in prefrontal cortex, see, there's not much in there in prefrontal cortex, you know. So they don't use it as much as, they're not exercising it in certain situations, relatively speaking. So impulse control, what did we do with impulse control? We did an experiment where the kids have to press the button every time there's an aeroplane and stop when there's a stop sign. So we saw how the brain works when they're able to stop. Okay, so the impulse control. So that's the experiment the kids did when they were lying in the scanner, and what we showed was these areas of dorsolateral prefrontal cortex were not very active, and neither are the ventrolateral prefrontal cortex in these patients. When you give medication of the right kind, then there is a better blood supply to those brains, and it started to work very well. So another thing is interface of emotion and cognition, or thinking and feeling. How do you problem solve, right? And so we showed all these angry faces and happy faces and also neutral faces. And what happened was, when we showed also these negative stimuli like jerk, nasty, and stupid, all these negative words, when they have to match them with the dots here, another puzzle they had to do, then the brain switched off in bipolar disorder. See the blue color? This is the healthy controls. So when the patients are needing to think and feel at the same time, the healthy controls are fine. But with the patients, they're not really, the blood flow is not going here in bipolars. So you can see when they're highly emotional, exposed to these negative stimuli, they can't work. Right? This is the fundamental slide that changed a lot of how we think in kids in America, at least in bipolar world. That has changed. These findings have changed how we think about even discipline. Okay? So we literally showed how the negative stimuli switch off blood supply to the thinking and feeling part of the brain and the interface. And this is when you even subtract, this is on top of what bipolar healthy controls reacted. Still, bipolars are overreactive, and also at the subcortical level, and underreactive at the front level. So in the same way, we showed like angry faces, and then asked them to tell the age, and then happy faces, and then just ask them to label the emotions. But they were able to label them fine. But when you actually have to determine something else unrelated to emotion, when the emotion sneaks in other words, then amygdala is fired up here. You see, quickly, within 200 milliseconds, it just fired up in bipolar kids, and not in healthy controls. So healthy controls, for example, the teachers are saying, oh, sit down, do this work. Okay, well, where is your homework? And then these kids would go in circles and react, and they just got really very, very upset, And so it's like, instead of a small reaction, they'll have a huge fire hose. You need to bring a fire hose for that kind of reaction. So that's, even this kind of faces, this is how they react. So there's a lot to be said about how to control these kids, yeah? So from what we know, these angry faces and the negative stimuli are really like not working very well. So it's almost like, the brain works like this. The front part of the brain, when they're little ill, it lights up. They're very ill, it just breaks. When you stretch, it works hard, and then its blood supply goes, and then it switches off and becomes blue when they're severely ill, like it's a broken rubber band. You see, that's how. So milder, it works hard, and then that's how the brain reactivity is. So pathophysiology of suicide and impulsivity is acting looking at the pathophysiology of suicide per se, acting without planning, reduced ability to suppress inappropriate responses, quick, poorly considered cognitive decision making is what we studied, and aim is to capture objective evidence through neurophysiology, right? And another one is decision making under emotional challenge. So emotional reactivity impairs cognitive decision making. So that was the aim, and our aim is to capture this objective evidence through neurophysiology. Now that we know how bipolars react and work and their brain functioning and everything, what do suicidal children feel and how do they react? So we showed them a synonym task where they had to match the words meaning, one word, negative word meaning needs to be matched, or neutral words need to be matched in meaning. Then what happened was, with these kids, response inhibition is really poor with them, and problem solving is also reduced with increased impulsivity, and it's most commonly seen with multiple suicide attempts. And if there is a stressor, then it increases substantially on the top of this relationship, and that exists. So impulsivity and decreased problem solving. And what is fascinating is these children did not rate their impulse control as being impaired. Their parents did not rate them, and their problem solving ability also was not captured in any paper pencil tests. It's only physiological neurocognitive tasks were the ones, impulse control as well as in that interface task of synonym matching task with problem solving. That's when we saw that they're disturbed at a neurocognitive physiological level. So you don't even know that you have these problems, and you might think you're normal, but there is a physiological impulsivity and reactivity that these kids who are suicidal are experiencing. This is basically one of our faculty's work that's in progress, which is funded by AFSP to us. So what did we do? What have we to do with these patients when they have all these problems, with or without suicidal ideation? A lot of them, in fact, more than 50% of them have this act, and almost all of them have the ideation at some point, or at least 90% of them. So what do we do with in treating them? So basically the most important things we published in an algorithm which we keep it alive, white paper, is prescription hygiene. Remember I told you no SSRIs, and mood stabilization is important. Problem solving through medication treatments, which means you address breakthrough symptoms of psychosis or aggression, depression. You address treatment resistance. You address sleep difficulties. You treat ADHD only after mood stabilization, not the other way around, because stimulants can worsen just like SSRIs and increase agitation and suicidality exponentially. So it is when you give medication, which combination you give medication, and what context you give them, and which order you give them. They're all important. We all, as doctors, have the same number of medications, but how we use them makes a huge difference. And adverse events are also important to think. Yeah, sorry. So normalizing and remodeling brain, optimizing the function is the name of the game, right? So brain is very plastic. So we actually did some experiments and showed how medications reverse the dysfunction in the brain. And I will do them really fast because they are kind of too much for understanding like in a bang like that, because it's like a decade of my work. So it's like suddenly telling you and saying, yeah, take it home, this is how it works, is not fair on you. But at the same time, I feel so excited that there's such a thing as happening here in the current day and age where medications are changing the wiring of the brain, reversing the function, and normalizing these children. And at least, to a large extent. And how you choose medications, which ones are based on how well they're working and which part they're working. And some medications work in one part of the brain, another ones work in another part of the brain. So you use a combination to make it all work. So you open the window of the brain, then you're able to look at how the brain is being reintegrated to function really well, okay? So just please pardon me when the next 3 slides are a little cumbersome, okay? But you are, now, DLPFC. We also are looking at lamotrigine, which increases like GABA. The GABA, it works at NMDA as well as it works through GABA as well. So it's a complex mechanism that lamotrigine has, and it works with calcium channels essentially, although it has complex activity. It increases the post-treatment activity change in overtime versus healthy controls. It increases the activity in all these regions in bipolar disorder. See, the rumination area, medial prefrontal cortex, the emotional CEO, thinking CEO, the middle managers, basal ganglia, and the attention area. And then, you know what, this is the affect inhibitory circuit. We also did the circuitry wiring and how they're all connected, and divalproex or Depakote helped with the middle manager here. And then insula, remember I told you about the bodily emotions? Risperidone helped in increasing the connectivity with the insula. When we probe this impulse control, when the kids are doing the task of impulse control and they're dysregulated, we gave this lamotrigine and saw the effect of the brain. And these regions of affective inhibitory circuit are all set right, and by these drugs in different areas, as you can see, and emotional areas are deployed during cognitive performance. So we are always thinking and feeling are interlinked, okay? And then it's working when they're doing the working memory task of remembering things. Again, this rumination area, emotional control area in the prefrontal cortex, and with lamotrigine and Depakote also did the same regions. And replication is present among anti-epileptic drugs. They're reaching the same regions, you see. And then risperidone worked in the same subgenual anterior cingulate cortex. It's a middle manager. It's an emotional moderating region, you know, it's increased. So they all increase the blood supply in those regions. And executive function, that's problem solving and attention control. Again, lamotrigine, risperidone, and divalproex, all of them worked in the affective circuit. And lamotrigine and risperidone also worked, together in this DLPFC area. And amygdala also is shown to have decreased with treatment with lamotrigine, but it didn't quite decrease until the medications are given for a long time. So what happens is the prefrontal regions are more plastic and change first before the subcortical reptilian old brain. It takes forever to change. You know, they're like old habits die hard, where you're very reactive. That takes a long time to fix. You know what I mean? I mean, you can, there's a saying in India, like, you only change when you die kind of thing with, and stuff. So, so it's a bit like, I wouldn't be so bad, but I'll tell you some of the tricks that we can just beat some of that, And so that's the D. The D is the trick. So this is the therapeutic part. So while we're doing all these medications, which are also individualized and personalized for all these people and helping with response inhibition and impulse control and all those things, and we figured out the brain model, we figured out how the medications are not quite figured out everything, but we're getting there to figure out most medications, how the brain is changing and normalizing. But we also feel each of us in this room have different problems. Each of us have different families, different aunts, uncles, and genes, and circumstances we live in. Although, like Anna Karenina's novel starts with, how difficult families or families with difficulties are different and happy families are the same. Who am I to question, the writer, who wrote Anna Karenina? But, Tolstoy, yeah. I knew Tolstoy, but then what if I don't get it right? Yeah, and so, so the happy families are also a little different, though. And we all have difficulties, and everybody has difficulties. Tell me one person, raise the hand, you don't have difficulties. I have a ton of them, too, over the years, lots and lots. So, how do you address those dynamics? When you treat them, each family needs to be embraced with that family's dynamics in that way that is pertinent. And you swallow some of the problems, you solve some of the problems, you turn this way, you turn it that way, but you don't overturn the whole thing and rock the boat. So that's kind of how I see the dynamics are very important to manage, I think. So that's why I feel brain and environmental training towards emotional resilience, the better. So I feel that, although we all have difficulties, the best has become even better is how we should all be thinking, and with resilience, and get our children to begin. Our children are the best, but bringing the best in them and improving and working on self-esteem is very important. In fact, self-esteem and family rigidity are the two things we found in our lab by Dr. Weinstein's work that are most important defining factors in moderating suicidal attempts. Okay, so it's very important to work on those two, and I will be talking about those. So the nature-nurture thing, right? Brain and environment, yeah? Brain and people. People that you have to manage are children, partners, school, family, friends, peers, sibs. It's no different than business done with much love. I always tell the mothers to manage the husband and tell the husbands to manage the wives, and it's a business, but it's a business with love. We all need to work with one another. It's interpersonal relationships, and that's what it is, mini MBA. So the emotion regulation, how do we do this? It's a child has to do it themselves, and then we have to also work with the parents and sibs and schools, teachers, peers, which is the environment, right? So the most important thing is slow down, right? When we have to really survive and think, first thing before you even think is slowing down, right? There's so much that crowds in our head. It's just too much stimuli. So how do you slow down? So this is my favorite, Viktor Frankl's, that inspired my next couple of slides. Between the stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom, right? So I want us to reflect on finding our growth and our freedom in how we respond to everything we do mindfully. Yeah? Then life becomes so interesting when we look at ourselves and respond, right? Poise. So I'm starting to work with Chicago public schools, charter schools, and writing a curriculum for their classes. And I call that poise because I kind of like that word poise. But it also is very nice, affect-regulated, thoughtful kind of behavior, I suppose. Education about brain function, tuning into facial emotions and cues, building skills to think under stress of negativity, which happens a lot in schools, mindfulness to regulate emotions, and preparing teachers to understand brain domain and be cognizant of compassion to envelop children is optimal environment, instead of really expecting them to do too much homework when they can't pull themselves together. There's a lot of cognitive problems. Remember, there are cognitive problems and emotional problems. We need to really understand that we cannot push these children too much. We have to understand, if we go to work and then say, oh, do this, and then if somebody asks me to do computer coding, how can I do it? I can decode people's brains by just looking at them, but not like really writing the codes for computer. The same way, children don't have all the skills. They're not born with skills, or they didn't learn the skills. So they may not have the strengths to learn the skills. So understanding that is very important. So parents and teachers need to understand that, and teachers need to understand kids, and we all need to work together on that one. Very, very important in moderating it, right? And so what we are doing in our lab also by a scientist called Rachel Jacobs, she is into this work, mindfulness, and we actually created this task in our lab called rumination distraction task or mindfulness task, and when these kids ruminate and this prefrontal cortex, the rumination cortex here. Remember I told you rumination cortex in the front, just between the thinking and feeling control places, that is hiked up. But when you distract yourself or you think about something and you don't ruminate, it falls down. This is the concentration area and thinking area. See how you can practice mindfulness. So that's all. So what is mindfulness, right? You just think about this. This one, you know, when we were students, we were not taught about mindfulness at all, okay? This is all new, right? I mean, it's been very, very old, like Buddhists and all those people did, monks and all that. They have 10,000 hours to do everything. We don't. So we have to really work with what we got, right? So how do you understand this? So I went left, right, center, and up, down, and I really trying to understand this mindfulness to the best of my ability. So what I think is, you want to be still, you want to listen. It's all about focus and being aware. There's so much attention you need to pay with mindfulness. It's not like sitting and letting go. It's sitting and listening and paying attention. That's what I figured out. You're sitting and paying attention to everything. It's not like just letting the mind and thinking it'll stop and sit in a corner and practice. And you let thoughts flow without judging, be in touch with the senses, focus on the breathing, and it slows down the thinking. So that's what slowing down is all coming to, is focusing. And knowing or disturbing triggers, Thich Nhat Hanh actually says, can be reminders to refocus on breathing in. So if there's a red light, you think, oh, that's my best friend. You know, I'm going to just breathe and focus on my breathing. Or if somebody is just nasty at work, I'll say, oh, that's a trigger for me to respond properly. Remember, we're going to find that freedom. And so respond. So every nasty thing is like reactivity for our kids and teens. We want to teach them that they are triggers to be remembering to breathe and take it slow. And smile as you breathe out, he says. But there is a deep sea of insights underlying the wave of outward emotions. So the way I write to my patients is, I draw a picture of like two eyes looking from the corner. They're your own eyes. You know what I mean? Like a cloak. And then you have up and down emotions. And then underneath those emotions, there's a deep sea of yourself and your insights, your thoughts, your feelings. All of them are inside. So if you just look at yourself and everything else around you, you can actually enjoy and understand even more and gain more and more and more depth to yourself and your thinking. So that's the mindfulness, I think, that we're talking about. So that is what is important, is to just, if you're bored, just be mindful. Then that's an interesting thing to do. Even when you're sitting in an airport, you could just be mindful and look at everything that's going on around and focus and think about it. And so that is slowing the mind. And think further, is, you know, stopping to not react. So the rainbow therapy is what we developed for the kids with mood dysregulation and impulse control, which are highly at risk for suicide, is routine affect control. Routine is having a routine affect regulation, and with medications, as well as watching yourself. With mindfulness, I can do it, is positive self stories, no negative thoughts, or living in the now for parents. Be a good friend, balanced lifestyle for parents, and also teaching them how to be a good friend, how to solve problems, ways to get support. These are all neuroscience informed intervention. We developed a psychotherapy in order to reduce that reactivity and reduce that impulsivity and increase affect regulation for these children with the high risk for suicide. And this rainbow therapy has shown to improve mania symptoms, you know. They've fallen down, the purple line, and depressive symptoms fallen down on the purple line compared to treatment as usual for bipolar. This has been published this year in American Journal of Psychiatry called Child and Family Focused Behavior Therapy, or Rainbow Therapy, that I just talked to you about. So it's a game changer, really. No punishment or provocative negative consequences or stimuli. So, you know what? We always think like positive, reward positive things and ignore the negative and then punish. No. These kids would kick the doors, push all the buttons of yours, and then make a hell in your house if you really give any punishment. So I think that you can influence them, you can help them to think about how to solve when they're calmer, and help engage them in a way that they would think with you with optimal problem solving in the rainbow treatment type thing, but no punishment or provocative negative stimuli, at least in the moment, or not, just say, that means I'm going to take your bike away or something like that, or take my phone away these days. That's a common thing. So manage reactivity through influence. We must change old ways of treatment. So this has really been one message that is a game changer in psychiatry, that we are pushing and trying to bring a difference. Environment, cultivate what you can, of course, and watch facial expressions, occasional demand change. Flexibility, remember, is an extremely high risk for suicide in families. So you want to be changing. It's a deadpan expression when they're yelling and screaming, and being difficult. Compassionate when they're sad and wanting to talk to you. A bit sad when they upset you and treat you bad, so that they know that they have really upset you. Because if you're too much deadpan all the time, they think that they haven't hurt you enough, and they go on and on. So being cheerful when they're happy and sharing their experiences, these are all the things that you move on with the children. You've got to be flexible, I guess, with those kids. Or with your partners or your friends. That's the way it is. The world rocks, I think. 0 to 100, ouch. Some of the kids just go 0 to 100. That's what families say a lot of the time. Some of these kids who are extremely explosive, impulsive, affect dysregulated kids, you disengage, you reboot, you use sense of humor, distraction, lighten up, chill, leave the room and lie down for a while and recuperate, mindful focus, think of role models, the deadpan, speed bumps, and you want to think about this mindfulness here. Think about how the brain works. So you want like the comfort blanket for your reactivity, your peace, your emotions. So think where your comfort blanket comes from. Priority is to de-stress the parents. In reality, 20 things hit you. So it's the same thing. You need people times, and you need to be centered and be with others. Ask lots of questions. Most people do not listen with the intent to understand. They listen with the intent to reply. Right? So, including me, charged guilty. So, I think that these, without expecting anything, sitting down and just not working so hard. We work so hard. That's the problem. We want to fix. We want to make it better. So leave it open, work less hard, and open your hearts and minds and just listen. Then maybe somebody will, the kids would open up to us more. And not, it's not about logic all the time, So half the skill is to shutting up and zipping your mouth, And that's where, sometimes the logic comes. And sometimes, the negative stimuli, kids can't do it, things can be done. And this is what they say. But parents must accept that it requires that extra effort due to illness. You know what I mean? These kids, 4 of them are fine. What happened to this 5th kid that I'm bringing? What have I done wrong, But they just it's just the way it is. The God dished out that way. Let's blame the God, right? And so you just got to go with the flow. And it's like, autism or diabetes or anything like that. You just can't see it. Now I showed you the brain, so you know that there's something going on without having to be tested. So which one are you? Cold, critical, compassionate, quiet, illogical, passive, rigid, optimal? I tend to be a bit like this sometimes. But sometimes we all switch between the two. So then sometimes kids take you for a ride and manipulate sort of thing. And sometimes, they feel that, they just feel annihilated. So it's really hard to know which ones you are. But I think that it's hard to find the balance, period, right? We try. So empathy, authoritative, and reasoning. First start with empathy, then things would at least be a little better. Full means consistently. You're full. I remember it that way. Empathic, so it's hard to remember on the spot. So that's how I think about it. Cruise control. Use metaphors in treatment. We always use metaphors. Use the right tone, stating the obvious, not yield but negotiating, or say, you got to want to keep that. Right. And perk up is patience, empathy, respect, and kindness. As I walked into this place, Omni Hotel, did you see the horse outside? The horse had respect written on it. You know, then I thought, wow, I wish that we all respect, one another and treat. And one way I told my mom when she used to get upset with, some of my siblings is, I used to tell them, treat them like next door neighbors. That would be really good. And so it's hard to do that, right? I mean, but practice makes it perfect, right? So nothing falls from the sky, y'all, I feel. So it's sort of like 50% is problem solving and 50% is making fun out of our own life, creating fun. Because it doesn't come automatically. You got to do your play dates, you got to do your parties, you got to do your friends, you got to do your mindfulness, you got to do your shopping therapy, whatever you want to do. But you got to do this fun part, and then there is this problem-solving part. 50-50 in my opinion. That's Mani Pavuluri's philosophy, okay? So, so family support. So it's just a slide I threw in. How, it's important to decode, previous slide. So first thing is, it's important to remember, these are the domains, these are the disorders, this is how the teachers say, this is how you think as parents perhaps. So we need to really bring the fact that they're all same, but you have to bring the paradigm together and bring it together to see how you help these children. Okay, so you think like this, not listening, and then suddenly someone says executive function, and then you say ADHD, and then someone says there's spelling problem. But the reality is ADHD, 70% of them have these reading difficulties, and this is nothing but executive function and sensory motor integration, and that's nothing but not listening and failing in class. You know what I mean? So you got to pull these things together. So I'll tell you why this is linked to suicide in 2 minutes, okay? So nothing happens like bang, like that. They're all related, It's not just one thing. That's why it's so complex. Suicide is not just one act that happens, but it may be. But there's a lot more pieces to the jigsaw puzzle that start from when they're like born. It's like a tree that grows, right? Sometimes we don't know everything. So hopefully for the future, we would be able to help with some of this. So this is kind of how, I don't want to go back through talking to you about all the brain stuff. This is how I educate families, talking about various things and what could be wrong and how they're all connected and how they're intense with reward systems and problem solving and all that. Oh, this is important. This is what I wanted to say. So precision treatment. So there are parent, SIB score, cognitive remediation, mindfulness, rainbow treatment at parent-child SIB level, all these treatments. But these are risk factors. Mom and dad should stop fighting. But these are all risk factors that are published by Dr. N, Dr. Weinstein, Dr. Brent, and a lot of people in the last month. And when I said I reviewed all these papers, there's a new edition that came in Child and Adolescent Psychopharm. Like the whole issue is on these risk factors. So this is nothing but these are the messages. If you take one message, it won't be enough to help. So I put all those messages together here, as well as whatever I thought was from old literature as well. Parental fighting, stop fighting. Perception of validation, how you feel you're supporting your child. What they see is more important. You may be supporting a lot by making sure they go in the right time to school, by packing their sandwich. But if you say, get on, it's time to go to school. I told you, oh my God, dad is watching you, just go, So that tone they'll pick up and say, you did nothing to me. You're just very nasty to me. But they forget about the 3 other great things you did. So the perception is important, guys, okay? Even if you just don't do anything, be nice to them. So perception and support for school, the school, go to school, teach, remember I told you about all the problems. If they think that they're really, really not doing well at school and they really feel, oh my God, I'm not doing very well, like in this, but the teacher is just nasty. I don't want to turn the homework. I don't want to do the homework. That's all. And then the teacher jumps on yells on the kid, and then they get the poor grades, and then the parents yell on the kids, and then the kids get upset, and then they don't know how to solve. They don't want to go to school. And so the whole thing starts on and on and on. It's not one day issue. And the arguments come, and then the parents fight over the arguments, the mom and dad. Oh, you are being lenient. No, you are being so strict. And they fight, and then they divorce. And so this is a chain reaction. Where it starts? Here in cognitive dysfunction at school. But do you track them all back? No, not often, because we are all human. We are so stuck in our family issues and all this kind of complexity. So that's why school support is important. It came up as one of the risk factors. Self-esteem, how the kids see, the rainbow treatment is all about it. Family flexibility, this what we talked about is all family flexibility. And then the boys, for boys, thinking that they have family support is important for them, I think. So that perception. Family depression needs to be treated in the family. A lot of family members have depression, so that need to be treated. Removing the means, the firearms, poison, and hanging. Remember all those things. Remove all the guns, remove all the medicines that are at risk when especially they're ill, and treat precision medicine. Remember I told you about the medications on brain function, and I have known several of people whose children went to the wars, and they come back and in transition to college killed themselves, a few of them. Very sad event. So they have PTSD, they have affect dysregulation. They also, some of them are inexplainable and horrific acts that happen, but I think that if you don't recognize the illness and treat them, whatever that may be, and think that they came back from war and just have psychotherapy, that's ain't gonna fix, I suppose. So I think that picking the nuances, it may not be a full-blown disorder, nuances of the complexity is very important, I think. And I just feel that, we can only move forward from here. And discovery is important. The research, and I'm grateful for American Foundation for Suicide Prevention, the discovery and the amount of all these findings are coming from AFSP. The skills are important clinically, because any research finding by itself does nothing. The clinical skills are absolutely important, and compassion, and they all must treat in treating every individual child. And I think, this way. And so I think that our people, we would like to get them to get the kids love their life. And Rob Hubbard sent me, one of the persons involved in Suicide Foundation, a message about losing his son and how hard it is to reconcile and how it is impossible to come back to accepting any of it, but only moving on with what are good in his life and all the goodies he has, and explaining how to get over the grief and bringing family support, people support, documenting his story and his pain, and reconciling with that is an emotional story he sent to me, and I'm happy to send it forward to you how he came to reconcile with that. Sometimes, despite all these efforts, there comes occasionally a choice that the teens or adults make, and it is when we move on and we live for today with help and giving forward with compassion, and we come together here doing just that. And I so appreciate, and this is dedicated to all those people who gave their lives and all those people who are struggling right now with mental illness, that I dedicate this talk to. And we move forward to help. And I want you all to join me in caring for the youth in the future. And feel free to contact me anytime if there's anything I can do to help in any way I can. A big thanks to our team. And actually, Jean Madigan is here in this room. I'm very grateful for you, Jean. And this is the Pediatric Brain Research and Intervention Center and Mood Disorders Program at IJR in Chicago, where we reside. And thank you so much for listening. I know it's a long talk, and you came on a day that's a working day, Wednesday, middle of the day, middle of the week, and I know I would never, go that easily anywhere. And the fact that you all came here and donated your time to listen and help some more is very, very appreciated, and I'm grateful for you to listen to me. Okay, thank you.